for coming. I'm William Wolf. I'm a psychiatrist on staff at the VA. And on the behalf of the selection committee, it is my pleasure to welcome you to the 14th annual Robert S. Wallerstein, MD, visiting lectureship in psychoanalysis and psychotherapy. We wanted to start with some thanks. And first of all, and most significantly, we wanted to thank the Wallerstein family and the contributors to the lectureship. That's why we're here, and that's what makes us able to be here. To the UCSF Department of Psychiatry, which has been the home for this lectureship from the beginning. To the UCSF Psychiatry Residency Training Program, which every year has made it possible for the residents to attend this lecture, and that is really important. I got to attend the first lecture by Otto Kernberg when I was a senior resident, and it made a huge impact on me, so I really thank you for that. And finally, to Jeana Martinez, who's right here, already standing. Jeana Martinez is the person who has protected and guided this lectureship from the very beginning. And I think more than anyone else, it's Jeana who's responsible for this holding environment that we have here. It allows us to unfold, and so we are very grateful to her. So a few words about Bob Wallerstein, in whose honor we are here today. Bob Wallerstein was an analyst. He was chair of our department from 1975 to 1985. And everyone I talked to about that time says that he fostered this environment of openness and curiosity. He may have done this through what I hear was a tremendous generosity to trainees and junior faculty, so really allowed things to evolve in a beautiful way here. But he also made significant contributions to psychoanalytic psychotherapy research. And as a reminder, in 1986, he published 42 Lives in Treatment. So this is the, I guess you could call it the Mueller Report, after his really decades-long research that he led. The psychotherapy research project at the Menninger Foundation. And like that other report, he followed the data to see where it would lead. And there were some unexpected results. He found that there were several treatments that had to be modified towards a more supportive direction, not expected. And that some of these supportive treatments actually had good outcomes, lasting personality change in a positive direction. And not I don't think, what he might have expected when he set out on this, but he followed the data. And I think that's a value to see what the data is, despite what it is that we might think we're looking for, that inspires this lectureship. And it helps us keep questions in mind as we start at the level of an individual case and go out from there. Most immediately, how do we know the treatment with this patient is working? And more broadly, how do we know that this model of treatment that we're using works? How does psychotherapy work? How does the mind work? And how do models of mental functioning hold up as neuroscience continues to advance? We have to use science to answer these questions. But how? How do we use science? George Silberschatz was our speaker last year, and he addressed a lot of these questions. And he told us, if you remember, if you were here, he told us that psychodynamic psychotherapy has a PR problem. And he's absolutely right. You go to any primary care doctor, and they will tell you that evidence-based psychotherapies are brief, manualized, cognitive behavioral treatments. So how do we get here? It's because the culture of medicine is dominated by the randomized trial. Now, randomized trials are a very powerful modality, but it's not a perfect fit with dynamic psychotherapy research. As it is, We have randomized trial is science. So what is it that's hard to fit? If you're doing a randomized trial of psychotherapy, you assume that if you group patients by DSM diagnosis, that you'll have a group that's homogeneous for the factors that matter. And then you can take from that group and randomize to standardized treatments, and then you go from there. I mean, that's the reason for DSM in the first place, isn't it? To be able to define these groups for investigation. But as George showed, grouping patients doesn't lead to homogeneity. And manualizing these treatments does not make therapists interchangeable. It's a big problem. As he pointed out, well, what do you do about the super therapists? Some people seem to have better outcomes than others, even when they're working with the same manual. So how does that fit in? What Jared showed us, and by the way, I encourage you to, if you haven't seen it, just Google Wallerstein Lectureship UCSF, and you can see his talk. But what he showed us is that dynamic research requires that you really zero in on what's happening with the patient. It requires extensive study. You need to break down what you're looking at into really individual units of psychotherapeutic process. And you identify intermediate variables, identify intermediate outcomes, and you work towards developing a process that's reproducible with inter-rater reliability. And what you get is a rich data set that's really invisible from the standpoint of a randomized trial, but does remind us of 42 lives in treatment. So good dynamic research starts with the patient and goes outward. It's the opposite of forcing patients into homogeneity, or trying to use manuals to make therapists interchangeable. Good dynamic research starts with the patient, but good dynamic therapy must use scientific principles in the treatment of individual patients. If I learned anything as a resident with Mark Jacobs and Marty Horowitz, it's that the foundation of dynamic psychotherapy is formulation. 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 So what is formulation? It's a falsifiable explanation for the behavior we see in the patient in front of us. In the case of control mastery, George told us about how the control mastery therapy is a continuous process of testing these explanations. We test, we see what result we get back, and then we have to respond flexibly to the information that we gather. So in control mastery, you ask, this intervention that I did, based upon my formulation, my hypothesis, was it plan compatible or not? Because if it's not, I need to adjust. So this is straight from Karl Popper. Scientific explanations must be falsifiable. But it's not enough. We want something more. A powerful explanation has something that the physicist David Deutsch, he calls it reach. An explanation has reach. If it's useful in surprising ways, it should be useful to us in domains that we hadn't anticipated, or for problems we didn't even think of when the explanation was put together. It should encompass everything that the prior explanation explains, but resolve new problems. So the example, Newtonian physics, it's a classic example. What reach that explanation has. So hundreds of years of bridges that don't collapse, hundreds of years of artillery that, for better or for worse, hits its mark. And problems around the margins, but seem that they could be ignored because of the reach of this thing. Along comes relativity, and it encompasses all of classical Newtonian physics. But the difference is that it also holds under conditions where Newtonian physics falls apart. So it solves new problems and has broader reach. We still have some problems around the edges with quantum phenomena, but maybe string theory will be the way we get through. So all of this is to say, so sorry for the detour, but all of this is to say that we want explanatory models for the mechanisms of psychotherapeutic change and the functional organization of the psyche that have reach. They've got to fit the clinical data that's in front of us. They've got to pay dividends in terms of treatment success. But they've got to hold up with the accelerating expansion of neuroscience knowledge. And that's why neuroscience has been woven into this lectureship. Because yes, we need to test our explanations of whether and how psychotherapy works. But because we need to broaden the reach of our explanations of mental function and psychotherapeutic change. And that's what takes us to this year's speaker, Dr. Mark Solms. And I'll give you a little background to clarify why I'm making that claim. Dr. Soames is chair of neuropsychology at the University of Cape Town. He's an analyst. He's president of the South African Psychoanalytical Association. He's research chair of the International Psychoanalytical Association. But he's also a neuroscientist. He's made significant contributions to our understanding of the neuroscience of dreaming. He's written over 250 articles, book chapters. He's written 6 books, including a bestseller, The Brain and the Inner World, An Introduction to the Neuroscience of Subjective Experience. It's great. So analyst, neuroscientist, explainer, and from what I gather, he pretty much created the field of neuropsychoanalysis. He founded the International Neuropsychoanalysis Society. He's a founding editor of the Journal of Neuropsychoanalysis, director of the Arnold Pfeffer Center for Neuropsychoanalysis at the New York Psychoanalytic Institute, director of the Neuropsychoanalysis Foundation in New York, and the Neuropsychoanalysis Trust in Cape Town. And on top of all that, Dr. Soames is the authorized editor and translator of the 24-volume revised standard edition of the complete psychological works of Sigmund Freud, and the 4-volume complete neuroscientific works of Sigmund Freud. So that's a monumental undertaking, more than 20 years of work on his part, basically picking up where James Strachey left off. So it seems to me that no one is in a better position to clarify the evolution of Freud's thinking, to really spell out what's the mature vision of that model, and to propose how can we revise that model to broaden its reach. So on behalf of the committee, it's my tremendous honor to introduce our distinguished speaker for the 14th annual Robert S. Wallerstein Visiting Lectureship in Psychoanalysis and Psychotherapy, Dr. Mark Solms. Part 1 of this year's keynote address is entitled, What is the Unconscious and Where is it Located in the Brain?
Thank you very much. It's great to be here, and thank you to the Wallerstein family. I had the pleasure of listening to Bob Wallerstein summing up the annual research conference at the Anna Freud Center every year. I lived there from 1988 to 2002, and it was, I hope I can do half as well as he did in this lecture today. I'm really delighted to have so much time. I hope you know you're in for a 2-part lecture, because there really is a lot that I want to talk to you about. I've been, it is a bit feedbacky. Yeah. I've been at it, this thing that came to be known as neuropsychoanalysis. I've been at it, if you date it from my first paper on that topic, since 1986. So that makes 33 years. And I was reflecting on when I was planning to say this to you as I began, on the fact that really means my own work has occupied a little bit more than a quarter of the entire history of psychoanalysis. It's actually a very young science. So it's not surprising that we still have so much to learn, and that's really what I want to talk to you about today. What I've learned over the last 30-odd years that I think is of relevance to the clinical practice of psychoanalysis and psychotherapy. So this is not going to be a sort of overview of everything that we've learned or think we've learned in that field, but rather an overview of those aspects of what we learned that I think have practical clinical implications. Now, I'm aware that many of you, if not most of you, are not psychoanalysts or even psychotherapists of any description necessarily. So I'm tailoring what I have to say to that fact. And also I'm going to make some remarks which I think are of more general relevance to psychiatry. But that will be more the sort of background to my talk rather than the main focus. So here are the two titles. As you just heard from William Wolff, the first part of my presentation is what is the unconscious and where is it located in the brain? And then after a discussion with you, and a coffee break, then I'll turn to this other enigmatically titled talk, Our Patients Suffer Mainly from Feelings. So let's start with the first one, the topic of the unconscious. Well, in fact, let's start with the topic of consciousness, because, of course, the notion of the unconscious only makes sense in contradistinction to consciousness. Freud was of the view, as were all the neuroscientists and neurologists of his day, that consciousness flowed in through our senses, that consciousness attached to perceptual functions, and therefore, ultimately, that consciousness was a cortical function. I say Freud, like most of like all of the neurologists and neuroscientists of his day, believed that consciousness was a cortical function, attaching fundamentally to perception. And in fact, the same applies to a very large number of neurologists and neuroscientists still today. But just in case any of you doubt me, I thought I would put up a little quote showing that that's what Freud thought. What this says, and I'm starting a little bit above the... I don't know if this is even shining on that screen. Anyway, I'm starting a little bit above the darkened part. He says, what consciousness yields consists essentially of perceptions of excitations coming from the external world. And then he says, and the feelings of pleasure and unpleasure which can only arise from within the mental apparatus. And he says, it's therefore possible to assign to the system perceptual consciousness a position in space. In other words, it's possible to localize it. It must lie on the borderline between outside and inside. It must be turned toward the external world and must envelop the other psychical systems. And here's the important bit. It will be seen that there is nothing daringly new in these assumptions. We've merely adopted the views on localization held by cerebral anatomy, which locates the seat of consciousness in the cerebral cortex, the outermost enveloping layer of the central organ. So therefore it says not only what I've just told you he said and believed about consciousness, but he, more importantly, admits or declares that the reason that he believed this is because the cerebral anatomists told him so. This was what everyone knew. The seat of consciousness was the cortex. I want to draw your attention to one further sentence because it turns out to be quite ironic. He says cerebral anatomy has no need to consider why, speaking anatomically, consciousness should be lodged on the surface of the brain instead of being safely housed somewhere in its innermost interior. As it turns out, that's exactly where it is safely housed. Here's another quote from Freud, which I won't read you. It's just in case there's any doubt in anyone's mind that Freud believed that consciousness was a cortical function. He said in the last quote, that it attaches to perception of the external world. But there was some mention of feelings there. And so I thought I should show you this quotation too, where, thank you very much, where he says that feelings too, affective sensations too, are ultimately cortical functions. So there's really no question about it that that's how Freud saw it. Now, that view began to change some 10 years after Freud's death, when in 1949 Magoon and Maruzzi discovered to their great surprise that consciousness is in fact an endogenous property of the brain. It does not flow in through our senses, and it does not especially attach to perceptual processes. Perceptual processes only become conscious to the extent that they are activated from within. And the famous reticular, this is also not much of a pointer, but the famous reticular activating system discovered by Magoon and Maruzzi is what I'm talking about. Unless these structures are activated and activate the cortex, activate the forebrain, then there's no consciousness. This is what wakes us up in the morning, and this is what puts us to sleep at night. We now know, in fact, on the basis of recent work, that it's possible to obliterate consciousness entirely with a 2 cubic millimeter lesion, a teeny-weeny matchhead lesion in the parabrachial nucleus of the reticular activating system, obliterates consciousness entirely. So there's really little doubt that consciousness is generated from within the brain, from within the core of the brain. It's safely housed in its innermost interior, and cortical consciousness arises from the endogenous activation from the brainstem. As I said, this we've known since 1949, but it was such a surprise when we first discovered it that we didn't quite know what to do with this observation. And so what we did, following Magoon and Maruzzi, was to draw a distinction between the level of consciousness on the one hand and the contents on the other. The contents of consciousness, that is to say its qualities, we retained the old view about them and said the qualities of consciousness are the qualia of our 5 perceptual modalities, and they do still attach to the cortex in a modality-specific fashion, so that somatic sensation, so-called touch, arises from here, hearing from here, vision from here, and so on. You can't see the olfactory and gustatory cortex, but the same thing applies there. These are the contents of consciousness, its qualities. And the upper brain stem regions that Magoon and Maruzzi had identified were then held to be responsible for the level of consciousness, that is to say its quantitative dimension, sort of volume control. And this was how we dealt with the really quite a shocking observation that consciousness, in fact, the switching on of the lights doesn't flow in from the outside, but rather comes from within, from this upper brainstem region. But that turns out to not be true at all. And this is the thing when I said some neuroscientists and neurologists still speak as if consciousness were a cortical function. And this is the bit that some of us are still busy catching up with, because again, it's something of a sea change. But really the upper brainstem structures that are responsible for the so-called level of consciousness that we measure on this 15-point quantitative Glasgow coma scale, that it's far from true that it only generates a level of consciousness. As Mesulam named it, he said it's really better to say that this generates states of consciousness. It's not, this aspect of consciousness is not something that only anesthetists or neurosurgeons are concerned with. It is, in fact, the aspect of consciousness that is mostly your domain. Psychiatrists, although they don't normally think about it this way, this is actually the part of the brain that you're acting, your drugs act on for the most part. Classical psychoactive medications like antipsychotics act on the ventral tegmental area over there, blocking dopamine transmission. The SSRIs act on the nucleus locus, on the Rafe nucleus, the drugs that act on noradrenaline. The source cells are down there also in the nucleus locus ceruleus complex, and so on. These are not arousal generating structures in the purely quantitative sense, but rather they generate affective states. The mood that you're altering with mood altering drugs is something that the neuromodulatory systems have their origins in this part of the brain. So this is, as I say, the thing that's changed in recent years. From the early 2000s, or in fact the late 1990s, we started to realize that it's simply not true to say that what these structures do is just generate a level of consciousness. It's just a purely quantitative dimension. It generates a quality of its own, and remember this quality called affect, which is generated by this part of the brain and the limbic structures arising from it. This is the foundation of consciousness. It's not just a sixth perceptual modality. As I said, you can make lesions as small as 2 cubic millimeters in size in these structures, and you obliterate consciousness entirely. The opposite does not apply. Here, for example, is a child with hydranencephaly, a 3-year-old girl, absolutely no functional cortex. She has a little flap of occipital lobe, which is totally gliosed, with no white matter connections to the thalamus. Effectively no cortex at all. And yet this child is conscious. She wakes up in the morning, she goes to sleep at night. She has absence seizures where even her parents can see that she loses consciousness. Most importantly, as you can see from this little photograph, it's not just that she has a quantitative switching on of the lights in the morning and switching off of them at night, but also she feels emotions. And there she's responding to her little brother being put on her chest, and when he's placed there, she goes, ah, like this, and clearly enjoys the experience. The purely affective experience, I have to say, because remember, she has no possibility of any conscious perceptual images of what's going on. She just has unconscious information going to the superior colliculi, and then the upper brainstem structures respond with this affective feel, which generates the sort of state that you're seeing there. Here's another child. This is not some unique thing. It applies to all of these kids if they survive. They have consciousness and they have feelings, and the feelings that they have are appropriate, affectively appropriate reactions to the sorts of stimuli that are applied to them. So the upper brainstem, the source, the font of forebrain consciousness, is not just a quantitative thing, rather it has a qualitative dimension. That dimension is affect, and affect seems to be the fundamental form, the elemental form, the basic form of consciousness. There are all sorts of lines of evidence for this view. I'm going to speak at quite a clip, because although I have lots of time, there's a lot I want to tell you, so forgive me if I just zoom over things. You're going to have lots of time for discussion. If you want to drill down to any one bit of this, I'd be happy to return to it. But here's just one example. Here's a PET study by Damasio from 2000, and what you see there in these four sort of basic emotional states is that not only is the activation all in subcortical structures, for the most part in brainstem structures, but if you look at the cortex, it's actually deactivated for the most part during these states. So affective consciousness is generated in the brainstem. It's not generated in the cortex. The old view is simply wrong. In fact, you can see the same thing by patients with cortical lesions. They are far from being less affective. Think of frontal lobe patients. Affects are disinhibited by cortical lesions. If affects were generated in cortex, you would expect the opposite. In fact, with decortication of rodents, Jacques Panksepp loved to tell the story about how his graduate students were incapable of telling the difference between two groups, one group of whom had been decorticated and the other not. But when forced to choose which group were the decorticated group, they chose the other group. They swapped them around because the decorticated animals were more lively, and so, they looked sort of more conscious. So there's really all sorts of overwhelming lines of evidence for the fact that consciousness is generated in the brainstem, and that consciousness in its fundamental form is affective. Here's just one further such line of evidence. If you stimulate with deep brain stimulation, in this instance the substantia nigra, this is a patient who had absolutely no psychiatric history, a 65-year-old woman who accidentally, the electrode which was meant to go a little higher in the subthalamic nucleus went down into substantia nigra, that is to say into the reticular activating system, and this is what happened. The patient's face expressed profound sadness within 5 seconds. Although still alert, the patient leaned to the right, started to cry, and verbally communicated feelings of sadness, guilt, uselessness, hopelessness, such as "I'm falling down in my head, no longer wish to live, to see anything, hear anything, feel anything." When asked why she was crying and if she felt pain, she responded, "No, I'm fed up with life. I've had enough. I don't want to live anymore. I'm disgusted with life. Everything's useless. Always feeling worthless. I'm scared in this world," etc. I won't read you the whole thing. When the stimulation was switched off, the depression lifted. In fact, she was hypomanic for a brief period, and then she agreed to have the stimulator switched on again with some blind trials, and whenever the stimulation was in the reticular activating system, specifically in the substantia nigra, obviously shutting down dopamine, then this is the response that we saw. So all of these different lines of evidence making the point that upper brainstem structures are where consciousness is generated, and consciousness in its fundamental form is affective. those of you who want to read a nice review of all of this evidence, this is the paper to read by Bjorn Merker, Consciousness Without Cerebral Cortex, Challenge for Neuroscience and Medicine in BBS 2007. Now, it's not only the point that I've made so far is that the old idea that consciousness attaches to perception, that consciousness flows in from the outside, that consciousness is an intrinsically cortical function. It's not only that that's not correct, that it's in fact a brainstem function, and that the fundamental form of consciousness is an affective form of consciousness. It's not only that, the point that I've made so far, but also this, that since the 80s and the 90s, we've learned in cognitive neuroscience that cortex is capable of performing all of its functions without consciousness. So it's not only that consciousness is not an intrinsically, inherently, fundamentally cortical function, but rather an upper brainstem one. More so, cortex can function without consciousness. And this is a famous review paper beautifully titled by Baj and Chartrand, The Unbearable Automaticity of Being, summarizing the abundant evidence for the fact that all of our cortical functions can be performed without awareness. In fact, they come in this paper this is from the late 90s, they come to the conclusion that 95% of our goal-directed cognition, execution of goal-directed cognitions, the cognitions are unconscious to the human subject. So this is not a controversial view. I'm not telling you something here. I'm sure I'm not telling you something that you don't know, that consciousness, that cortex can perform higher cognitive functions like face recognition, like reading with comprehension, without any awareness of any perception at all. The subject is not only unaware that they have read something, or not only unaware that they've seen a word, they're unaware of having seen anything at all, and yet you can show from their subsequent behavior that they indeed have seen and read and understood and been affected by what they've read. And this seriously led to the question, if cortex can perform all of these functions without consciousness, then what is the consciousness for? It's such a troublesome thing to be conscious. You know, why can't we just do without it and all just be zombies? This question led to the development of probably what has become the most mainstream view on this question as to what consciousness is for. This is the view that Damasio started to elaborate in the late 1990s. And that is that the reason that we have consciousness at all is precisely because consciousness is affective. The reason we have consciousness at all is so that we can have feelings. That feeling is the fundamental form of consciousness, and what feeling is for the organism to know how it is doing within a biological frame of reference, within a biological scale of values, where anything that is going to reduce the chances of surviving and reproducing feels bad, and anything that's going to enhance the chances of surviving and reproducing feels good. On Damasio's view, and it wasn't Damasio alone, Jaak Panksepp, who I mentioned earlier, was also very much part of the research effort in the 1990s, which led to this, as I said, now mainstream view, that the fundamental purpose of consciousness is affect, is to be able to feel qualities, and the basic quality is goodness and badness within a biological scale of values. It's not just... I'm not speaking only about basic bodily survival functions, although let me dwell on them for a moment in order to illustrate the point. I wanted to say in this slide, the red structures, these are all body monitoring nuclei that feed into the reticular activating structures, which then in turn activate forebrain. That's the sort of basic idea. But it's not just basic body monitoring, which, as I said, I'll dwell on for a moment, things like hunger. You know, the feeling of hunger, it's an unpleasant state. And then as you satisfy the hunger, it's pleasant. The feeling of thirst is an unpleasant state. This is how the organism knows it needs to do something, it needs to drink. And then the pleasure of satisfying that. All of this is reduced to basically to homeostasis. That there's a settling point where the organism needs to be in terms of all of its basic bodily parameters, in terms of oxygen and salt water ratios, blood gas ratios, core body temperature, etc. There's a place where you have to be. Deviations from that are felt as bad, so that the organism knows in an uncertain environment whether what it's doing is making matters worse or making matters better. It's not only in relation to these basic bodily functions, but also emotions, higher emotions. The same thing applies to emotions like lust. Perhaps you might not think of as an emotion, it might be something on the borderline, but something like attachment bonding. Being near to mummy when you're a mammal or a bird that is attached feels good, and that's the nirvana, that's that settling point, the homeostatic, the place that the organism needs to be. Deviations from that feel bad, and there's a particular quality of unpleasant feeling, in this instance separation distress, that the animal feels. And then in order to get back to where it needs to be within, in this instance, an emotional need, a need to be near to mummy, the pleasure of reunion regulates this function in much the same way as the pleasure of eating or defecating or sleeping in relation to more basic bodily needs works. So this is the sort of standard idea. This is how affects work within the framework that Damasio and Panksepp and the other mainstream views within affective neuroscience have developed. So this is a really very different view about consciousness from the one that Freud held all those years ago. However, Freud did believe that there were basic bodily functions which made demands upon the mind for work. Freud called these drives, or as the term was translated by Strachey, instincts. He said an instinct appears to us as a concept on the frontier between the mental and the somatic, as the psychical representative of the stimuli originating from within the organism and reaching the mind as a measure of the demand made upon the mind for work in consequence of its connection with the body. That is really, you could easily say that, well, that sort of summarizes this. That's how this works. There's a demand, the homeostatic deviation is a demand for work, and then the work is the moving of the animal back into its viable bounds. That's not at all incompatible with the basic Freudian idea of what drives the engine of the mind. Here is a rather longer quotation. The id, cut off from the external world, has a world of perception of its own. It detects with extraordinary acuteness certain changes in its interior, especially oscillations in the tensions of its drive needs or instinctual needs, and these changes become conscious as feelings in the pleasure-unpleasure series. It's hard to say, to be sure, by what means and with the help of what sensory terminal organs these perceptions come about, but it's an established fact that self-perceptions, kinesthetic feelings, feelings of pleasure, unpleasure, govern the passage of events in the id with despotic force. The id obeys the inexorable pleasure principle. So the foundation of the mind, Freud's id, which is tethered to the interior of the body, where demands are made upon the mind to perform work in the form of drives and instincts, and that these are felt as pleasures and unpleasures, is not incompatible with Freud. How are we to reconcile this with what I said to you at the beginning? Well, Freud had the whole thing upside down. Freud was of the view that these id functions, which as I've just described to you, are really pretty much the same, not pretty much, they are darned obviously the same thing as the structures that are, the functions that attach to these structures in the upper brainstem and the limbic system that I described to you earlier. Freud called these id functions, but he thought they were unconscious. And this is the very opposite of what we now are compelled to think. That the drives, these deep upper brainstem and limbic forces which drive the engine of the mind are far from being unconscious. They are, in fact, the font of all consciousness. This is the foundation of all consciousness. And these higher cognitive functions, these cortical functions, which Freud himself said were cortical functions, they are in fact intrinsically unconscious functions. They can do their job perfectly well without becoming conscious. And the question as to why we have consciousness at all, as I said, it has to do with the animal feeling its needs. And those needs then govern, through the activation, the secondary activation of the higher cortical structures, the animal's able to feel its way through its cognitions and in this way solve its biological problems in the outside world. Freud was of the view, based in the old cerebral anatomy, that consciousness has to be dragged down from what he called the perceptual conscious systems up there, has to be dragged down into the id in order for us to become conscious of these inchoate drives and instincts. And in fact, it functions. The reality couldn't be further from that. It is the exact opposite of that. So that's the first main conclusion that I wanted to convey to you in terms of my trying to answer this question: what is the unconscious and where is it located in the brain? Well, for Freud, the unconscious was part of something called the id. The id was unconscious and it was at the base of the mind, the part of the mind that's driven by biological needs, and in fact this cannot be the case. This is not unconscious. These functions are the font of all consciousness. Freud's view that consciousness was derived from external perception is incorrect. Consciousness, or rather I should say external perception, is not intrinsically conscious. Cognition is not intrinsically conscious. It borrows its consciousness from below, and the function of the consciousness is to feel your way through the cognitive functions. I'll have a lot more to say about that later, but we're trying to address where is the unconscious. Well, it clearly isn't in the upper brainstem. It clearly isn't in the part of the mind that perform, or the part of the brain that performs the functions that Freud called id functions. Now, before I move on, I want to say that we know now that we've identified these upper brainstem structures which are responsible for these basic drives and instincts. We've learned something else which is of interest to psychoanalysis, or should be of interest to psychoanalysis, which is that there are a great multiplicity of these drives and instincts, far more than Freud imagined. Freud thought that there were two fundamental drives. And they were, not to put too fine a point on it, sexual and aggressive, the so-called life and death instincts or drives. What we've learned about these upper brainstem and limbic structures is that there's a much greater variety. I'm going to very briefly run through these with you, partly because I think that it really is of interest to psychiatry in general, what we've learned about these functions. It's of great interest to psychotherapists and psychoanalysts, and that's going to be the main emphasis of where I'm heading. But for now, in reviewing these functions with you, I want to also point out some of the implications for general psychiatry. First of all, I need to tell you that there are three broad categories, and the different people classify these things differently. It's not really of that much interest how we classify them. Nature doesn't contain classifications. We impose our classifications. But there's sort of general consensus that these things exist, however you divvy them up. Within the classification that I use, which is Pankseps, there are three broad categories. There are homeostatic affects, which are, in fact, they're all homeostatic, so it's sort of badly named. Perhaps they should rather be called bodily affects, which are of the kind that I've mentioned already, things like hunger and thirst and sleepiness and the need to urinate and the need to regulate core body temperature, the need to, suffocation alarm would be an affect of this kind. These are very basic here and now bodily needs, which when you move out of your viable bounds, you feel it big time with extreme unpleasures which compel you to act in order to bring you back into the homeostatic range that is compatible with your phenotype. Then there's a second broad category which are called sensory affects. And these are very similar to the ones that have to do with here and now bodily needs, except they have to do with external sensations. And well-known sensory affects are pain or disgust or surprise. They are the immediate reflexive reactions to external stimuli of universal biological significance. Please note In all of them, there's a specific affect, a specific feeling. Pain is different from disgust, is different from surprise, just as the internal bodily affects. Each of them has a different quality. This identifies which need we are talking about. All affects have a valence, a pleasant and an unpleasant dimension in relation to the particular quality of affect that we're talking about. That identifies which need we're talking about. What they also all have in common is there's a certain action that the animal is then, by animal, of course, I'm including us, that we are impelled to perform in order to return to the expected homeostatic state. So, for example, in pain, there's a withdrawal of the limb. In disgust, there's retching. In surprise, there's paying attention, and so on. These are the technical term for these within the field that I'm reviewing for you, is that they're predictions. They're predictions as to how to return the animal to homeostasis. And many of these are built into the brain. You don't need to learn how to withdraw. That's why we call them reflexes or retching and so on. These are inbuilt predictions. The only reason that you have to feel them at all, and there are of course many autonomic regulatory predictions which we don't feel at all, like for example blood pressure regulation. The only reason that we feel the ones that we do feel is because there is some uncertainty as to the outcome. And so the animal has to use this quality of feeling, of pleasure and unpleasure, especially in unpredicted and novel environments, to be able to ascertain whether this is working or not. Think, for example, of finding yourself in a carbon dioxide-filled room. What do? You don't have a manual for that. You try different things out as to how, do I go low? Do I go high? Can I get out this window? Can I get through this door? And so the feeling of whether things are getting better or worse guides the animal's behavior, voluntary behavior, in an unpredicted environment, in a novel environment, which is an enormous adaptive advantage. This is what feelings are for. Now, I've told you there are three categories. I've told you about the basic bodily ones, and I've mentioned the external sensory, also basic bodily ones, the internal ones and the external ones. But then the third category is the one that's really interesting to you and to psychoanalysis. And these are what we call emotional affects. And I already have introduced the topic when I said earlier that homeostasis applies not only to bodily needs, but into all of our biological needs, including our emotional needs, which are much more complex. And I'm now quickly going to review for you what the 7 basic emotional needs are that we've identified in the mammalian brain. And in passing, I want to mention something of the relevance for general psychiatry. I have lust up first because, of course, this one Freud knew about. But we've learned a great deal more. I won't review. You all know what the sexual instinct is. You all know what the affect is, sexual desire. You all know what sorts of behaviors satisfy that desire. They really are quite simple in terms of the basic bodily movements that are required in order to satisfy lust. But things get more complicated because the lust by itself is not the only need that you have. So, for example, in pair bonding and in romantic love, there's a lot more that comes into the equation than mere lust. And you have to meet all of these needs in conjunction with each other. And that's what makes things a lot harder. And this is going to be a theme that runs through what I'm going to tell you now, that these emotional needs are hard to satisfy. They're much harder to meet than the basic biological and sensory ones that I spoke of earlier. I said this one Freud knew about already. What Freud didn't know is that there's a second very closely related instinctual need, which we call foraging. And Freud conflated these two things. If you look at Freud's description of a libidinal drive, it included both what we would call lust, the sexual instinct in the purely sort of veterinarian sense of the word, and seeking, which is a much more all-purpose, general pleasure-seeking, object-seeking, sort of curiosity and interest and expectation, a sort of an outward going into the world in the hope and in the belief and in the desire of finding something interesting there, finding something pleasant there. This is not the same as lust. Lust feeds into seeking, but so do all of our bodily needs. So the need detector mechanisms in the medial hypothalamus, all of them feed into this foraging instinct. You think of a dog in an open field, you plonk it there, it doesn't just sit what it does is it sniffs the air and twitches its whiskers and wags its tail and it explores. Sort of, what's out there? And the biological story is that whatever the animal needs, it's out there. And so in its foraging, so it discovers where it can satisfy its hunger and where it can satisfy its thirst and where it can satisfy its lust and some of the other needs that I'm going to tell you about later. Very important when I said I'm going to say things which are of some relevance to psychiatry is the fact that the activation of this system produces the opposite state of mind of depression. So this sort of enthusiasm, energy, expectation, hope, optimism, all of the things that a stimulation of this system creates, which, by the way, you can stimulate with cocaine or amphetamines, that sort of state of mind. The very opposite of that, the slump, the lack of energy, the lack of optimism, the lack of positive expectation, the lack of hope, this is the normal phenotype of depression, what we call despair. And if you overactivate this, you get mania. Of course, this system is important in addiction. It's a craving system. Nora Volkow has spent her entire career, more or less, studying this dopaminergic seeking system. So there's a system that has some relevance for mood disorders and for addiction, and of course those two things have something to do with each other. Here's a third one, which is rage. This is again a circuitry that is absolutely built into the mammalian brain. By the way, these 7 circuits that I'm describing to you are not uniquely human. They are found in all mammals. In other words, these are conserved over 200 million years or more. Rage, you frustrate the animal, there's the thing that it wants, here's the thing that's getting between it and what it wants, something that's in the way, this is irritating, this is frustrating, and eventually it's enraging, and what does the animal do? It attacks to get rid of the bastard, to get rid of the impediment, and again, this is something that we don't need to learn how to do. However, we do need to learn when to inhibit this. We do need to learn who not to attack. So it's unlike the basic drives that I spoke about at the outset, hunger and thirst and sleepiness and so on. There's quite a lot more learning from experience that's required, quite a lot more context dependency, and also a need to reconcile these different needs with each other. Imagine, for example, if I can tell you a real-life example, a young schoolboy is irritated by his headmaster. So the instinctual inclination is, this guy's in my way, what do? I hit the bastard. But as you know, if you hit your headmaster, things turn out badly. So you can't just rely on these basic predictions, these inborn predictions. One has to do something more. And in the real-life example that I'm talking to you about, the schoolboy in question thought, what will happen if I hit the headmaster? And then thought better of it, and then thought, what else might I do? And then had the good idea that when nobody is looking, he will let down the headmaster's tires. And in this way, he gets the bastard without being expelled from the school. And I assure you from personal experience, it works. Now, here is another one. Please note we're on number 4 already. There are more than 2 instinctual needs in the human brain. This is fear. We don't call it anxiety, we call it fear, because there are different types of anxiety in the brain. And in fact, I should have said when I mentioned rage, the same applies to aggression. We don't call it aggression, we call it rage, because there are different types of aggression in the brain. What I described there is hot aggression. That's why we call it rage. This, and all of these built in the facial expressions which Ekman uses as his main basis for classification and his behaviors and so on. That's what comes with rage. But there are other types of aggression, like, for example, a lion sees a springbok and chases after it and jumps on it and sticks its claws into it and rips open its throat and bleeds it to death and eats it up. It's pretty aggressive, pretty violent, but it doesn't hate the bastard. It loves it. It's lunch. And that is driven by seeking, not by rage. There's a third form of aggression which I'll come to later, which we call territorial aggression or dominance behavior. It's sometimes called intermale aggression, although it's a bad term for it because it's not, of course, only males who show this sort of aggression, which has all got to do with who's who in the zoo and making yourself big and making a big noise. You're talking to me? Here's the line. You're talking to me? Fuck you. You know, this kind of, like a dog defending its territory, barking and barking, and trying to make itself as big as possible. As we say in English, there's more bark than bite. And when they do bite with this sort of territorial or dominance aggression, it's little nips. It's not trying to kill. So this too is important, I should imagine, for psychiatry to differentiate between the different forms of aggression. Think, for example, of a rapist, if I may use a terrible example, who's motivated by rage, hot aggression, as opposed to cold, predatory aggression. It's a very different kettle of fish that you're dealing with. Sorry, I was speaking about fear. I was saying that there is more than one form of anxiety in the brain, but this is trepidatious fear. When there's risk to life and limb, there's built-in predictions. Again, one must freeze or one must flee. These are the innate predictions, but again, it's not enough. It's not enough to, if this is the only prediction that you have as to how to meet your need for safety to life and limb is to freeze, then, you know, this is not exactly always the best idea. It's not exactly always the most adaptive thing to do. You also have to decide, shall I fight or shall I flee? And so these judgments have to be made. And all of this is why we have cognition. All of this is why you have to feel your way through these things and learn from experience how to meet these needs. There are built-in triggers for fear anxiety, which interestingly coincide with the common phobias. And they vary from mammal species to mammal species. Like, for example, in rodents, a newborn rodent, on the first day of its life, you put one cat hair in its cage, it will freeze. It's never met a cat, it's never discussed cats with its parents, doesn't know anything about the general sort of attitudes of cats to mice, but still it will freeze. But then you have to learn what else to fear in life. Like, for example, electrical sockets. We have to learn not to stick our fingers in them. And you can't possibly have this, can't possibly be an innate stimulus. So we have to learn things that evolution does not predict, things that we find in unpredicted environments. This is what feeling is for, so that we can learn from experience and nuance our instinctual responses. This is the second major form of anxiety, which we separate from fear anxiety. This is panic anxiety. And just as antidepressants help panic anxiety and benzodiazepines help fear anxiety, this is because these are two different chemical systems, two different circuits in the brain. Panic anxiety arises with separation distress. If the once attachment bond has been made, which in our case, the human case, it takes for up to 6 months to occur, then you separate the little one from its caregiver that it's attached to. What it does is it panics. We call it protest behavior. Mama, wow, separation, distress vocalizations, and searching for her. Mama, mama, you lost me. And trying to reestablish reunion. If that does not occur within a relatively short period of time, then the animal slumps into despair. So from protest to despair, and that's why this is called the panic grief system. The normal phenotype that I spoke of earlier for depression, the shutting down of seeking, we know that this is the separation distress cascade. The low mu-opioid receptor binding is what characterizes panic, the protest phase, and then there's rising kappa opioids, dynorphins, shut down dopamine, and then the animal goes into this slump. Very interesting, I should imagine, for psychiatry in general, and also for the way in which we are classifying psychopathologies, is the so-called high comorbidity of panic disorder and major depression. Why there should be such high comorbidity is not a mere statistical observation. It reflects the fact that these are two sides of the same coin. It's one and the same functional system. A system in the mammalian and in the bird brain for attachment, and for the maintenance of attachment, and for the mediation of separation and loss responses. All sorts of other interesting things had our time that we might talk about here include the fact that OCD, for example, is mainly panic anxiety when you study it rather than fear anxiety. And so it tells you something again about why these comorbidities exist in terms of these underlying phenotypes. The point that I'm trying to make implicitly is that I think that the understanding of these basic instinctual emotional systems of the mammalian brain is a promising avenue for reconsidering how we carve psychiatric nosology up. It may be a better basis for classifying psychiatric disorders in some ways than the artifices of the DSM. So what number am I on now? It's lust, seeking, rage, fear, panic, that's 5. Here, by the way, it's just showing that it's the same circuit in a guinea pig as it is in us. And also I wanted to point out that the interaction which I just spoke of between the panic grief system on the one hand and the seeking system on the other, the seeking system here shown as the medial forebrain bundle in green over here. This is the basis also for deep brain stimulation treatment of chronic treatment refractory depression. As you no doubt know, Helen Mayberg had such dramatic results with the stimulation of the upper end, the top end of this circuit. The white matter just under the subgenual cingulate over here is where she stimulated and got such dramatic responses in these depressed patients. And Volker Kernan and his group stimulated into the medial forebrain bundle, which turned out to be the best site. They also tried the nucleus accumbens. And you see dramatic changes in the mood of the patient right there and then on the operating table. Here's system number 6, which is nurture and care. Again, something built into the mammalian brain as much as, some social movements hate to admit it, that there's such a thing as a nurturant instinct. It's by no means a uniquely female inclination, but it is mediated by estrogen, prolactin, progesterone, oxytocin, all of which are higher on average in female mammals than males, especially during pregnancy. The last is the most interesting of them all, which is play. Mammals need to play. They have to play. If you deprive a juvenile mammal of half an hour's play today, it will make up half an hour's more play tomorrow. And so this is a very interesting thing, because why should, it's easy to understand why rage or lust or fear, are of biological consequence, and why these should be instinctual needs that are built into our brains. But play, it's by definition not even real. It's play, pretend. And yet we need to do it. And so this raises the interesting scientific question as to why do mammals need to play? What is the biological advantage that's bestowed by play? And this is where that third form of aggression that I mentioned earlier in terms of dominance and territoriality seems to find its home. If you study play, the interesting thing is that the majority of play episodes, despite the fact that children enjoy it so much, in other words, there's an enormous evolutionary reward that wants us to play. This is what the fun of play is. Somehow it's for something. Why is it such fun? Despite the fact that it's such fun, empirically, the majority of play episodes end in tears. And so this is interesting to study why and how does play end in tears. It suggests something about what play is all about. What we find in studying how play episodes break down is something that's called the 60-40 rule. The 60-40 rule states that the two playmates will carry on playing. It will be fun for both of them as long as one of them doesn't try to dominate more than roughly 60% of the time. In all play, if you think about the prototypical play, which I have on the screen there, rough and tumble play. Here, by the way, if you can see it, are some rats doing the same thing as these chaps are doing. Rough and tumble play. We all do it. The way that it works is the one animal invites the other one, like if it's a dog, they put their backsides up in the air, they put their forelimbs low, and then they jump around like this. That means, do you want to play? And then it runs. And the one animal chases the other, and then they do the dog version of this. And then they swap over. The one's on top, the other one's on top, and then the one that was being chased chases. And this is how rough and tumble play works. So there's one who dominates and there's one who's submissive. This generally, I'm sorry to tell you, generally what happens. One kid dominates the game and the other one kind of goes along with it up to a point. And that point is this roughly 60-40 thing. If it's never your turn to be on top, to be the one who's dictating the action, then it's not fun anymore, and then you say, I'm not playing. It's not fair. And the not fair, has to do with the 60-40 rule. I mean, think about the most common games, cops and robbers. Cop, robber, doctor, patient, mummy, baby, cowboy, Indian. I'm not saying cowboys should have dominated Indians, but they did. Teacher, victim. There's always a hierarchy, and it's fun. It's fun, and if you think of playing cops and robbers with your little brother, it's fun. You lock him up. And it's fun for him, yeah, I'm the robber, you're the cop. But if you then throw away the key, it's not a game anymore. Now you've locked up your brother. And so and it's 100% you're on top and 0% for him. So there's no fun in it for your little brother. This crossing of the boundary is, we think, a very important part of what play is all about. And I've mentioned the 60-40 boundary, and it could also be conceptualized in terms of the boundary between play and one of the other instincts, so that if it becomes real, it's actual locking up your brother. Then it's not play, it's real rage or real fear in the case of the brother. Playing doctor is a game until there's real lust involved, then it becomes sexual abuse. And so this is also this finding the boundary of what is acceptable, how far can I go, what is permissible. We think that this is a very important part of what play is all about. Play requires the animal to take account of the feelings of its playmate. Otherwise, the game breaks down. And the reward, the fun, is then lost. So the bully sits there with all the toys, but nobody wants to play with him. Play requires prosocial and empathic interaction. And we think that play is an important part of how stable, viable social groupings work. Hierarchies, I'm afraid, it is all about dominance and hierarchies, especially as you move into adolescence and play becomes more organized and, frankly, and obviously competitive. There's a nasty side to play. If you think back to your own childhood, play was a bloody serious business, whether you're up or down, and in or out, or, it's a bloody serious business. But we think it's an important pro-social instinct. Anyway, so to sum up, what I've told you is that we've learnt two things of relevance to this question as to what is the unconscious and where is it located in the brain. The first is that it is not in the cortex. That consciousness is in the lower brain stem, the part of the brain that performs these id functions, these drive functions, these instinctual functions, that these are conscious functions. And so the idea that the unconscious and the id are the same thing is something that we really have to recognize is a fundamental conceptual error. And this has massive implications for how we think about what we do in psychotherapy and in psychoanalytical psychotherapy, and that's where I'm leading to. But for now, I just want to point out, in terms of answering the question, where is the unconscious and where is it located in the brain? Well, it's not, what is the unconscious? It's not the same thing as the id. It's not the instinctual, driven pole of the mind. That is the font of consciousness. It has everything to do with consciousness. In fact, it is the primary form of consciousness, which then activates these cognitive forms of consciousness, which was where Freud thought consciousness is derived from, this extraceptive, cognitive, cortical type of functioning, is not intrinsically conscious. The reason that it becomes conscious is so that we can solve our problems out there in order to meet our needs, these more basic id functions, as Freud called them. And then secondly, while I'm at it, the second point that I've made is that Freud's id, which was meant to contain two instinctual drives, in fact contains 7 of them if you only include the emotional ones. leaving aside the more basic bodily needs, just in terms of emotional instinctual needs, the 7 that I've summarized are big-ticket items, and they are different from each other. The attachment, for example, and lust are not the same thing. Freud thought they were one and the same thing. We're dealing with 7 moving parts in the conflicts of the mind, not just with 2. And I emphasize the word conflicts because as much as I've already emphasized that each one of these needs is hard to meet, it's hard to learn how to manage rage, how to manage fear. You need to learn what else to fear, whether to attack or to flee, what else to do other than to flee, etc. All of these things have to be learned. But then also, the second point which I've touched on, but what I want to really underscore now, is that bringing these things into conjunction with each other makes it even more hard to learn how to meet our emotional needs. Think about attachment bonding. You know, in attachment to that panic grief system that I told you about, the prediction is I must do everything in my power to keep mummy close to me, to keep my caregiver close to me. And when I am close to her, I feel safe and secure and fuzzy and warm, and it's all very nice. And I want it to stay like this always. That's the prediction. Whereas with rage, anything that frustrates you and irritates you and gets between you and what you want, you attack the bastard in order to destroy it, to get rid of it. What if mummy frustrates you? You know, then you have 2 instinctual responses which are directly contradicting each other. And this applies across the board in instinctual life. In order for us to meet these instinctual emotional needs, we are constantly in a state of conflict. And we feel the conflict. Remember, none of this is unconscious. The feelings are all too conscious. And the task of cognition is to learn how to resolve these dilemmas, how to find some sort of synthesis, some sort of configuration whereby in this situation I can do that, in this situation, what works? How do I meet my needs? It's hard to learn how to meet your emotional needs. Hence the importance of all of these forces in psychopathology. Think of romantic love, which I mentioned earlier. As I said, it doesn't involve only lust. Ideally, it must involve lust. But how do you bring lust into conjunction with attachment bonding? It's quite a weird thing, especially when you consider who your primary attachment object is. It's quite hard to bring these feelings together, as psychoanalysts learnt a long time ago. But then the attachment part of romantic love has to be reconciled with seeking, which is always sort of like, I want to keep her with me, always safe and sound, but what else is available, you know, is what seeking is all about. So to reconcile all 3 of these things with each other, let alone with rage, you know, and so on. So this is how we might think about why it's so difficult to learn in the case not of our bodily needs and our sensory aspects, but these emotional needs. To learn how to meet them in life is a hard thing. That is the function of cortex. That is the function of thinking. That is the function of conscious cognition, feeling our way through life's problems. Once you've solved the problem, you don't need to be conscious of it anymore. And I'll have a lot more to say about that in a moment. I now want to come to this conclusion. The id is conscious. In other words, the needs of the body and the needs of the organism, the emotional needs, are felt. They are heartfelt. They are only too conscious. These things are not unconscious. So the id, what Freud called the id, these needs are conscious functions, and the task of the ego is to get you back into your homeostatic settling point, back into the range where the need is resolved. And so the aim of ego functioning, the aim of cognition, is learning how to meet your needs in the world in order to damp down the feeling, in order to regulate consciousness, in order, ironically, to minimize consciousness. The ego has performed its job most successfully when you're back in the settling point and when the feeling has gone away. Think about it in terms of the simple examples I've given you. You know, I'm hungry. That's bad. My prediction is I must eat. It works. Great. So pleasant feeling, predicting you're going in the right direction. Then eventually they eat. You don't carry on eating and eating and eating and eating until you explode. You reach satiation. And that's the feeling then disappears. That's the ideal. That's what we're aiming for. And the same applies to fear, and the same applies to rage, and the same applies to separation, distress, and so on. You're trying to get to the point where you're in the zone, where you need to be, where the feeling disappears. So the aim of all of this thinking consciously, all of this trying to resolve life's problems, is to get back into a state of zombiedom, which is actually what the ego aspires to. Learning how to meet your needs means not having those needs, of course, we never actually reach that point, but ironically, it's the very opposite, therefore, as I said, of what the classical Freudian model would have had us believe. That's not that the id is unconscious, the id is the source of consciousness. And it's not that the ego is the source of consciousness, the ego is trying to resolve the consciousness, the fundamental form of consciousness, the fundamental source of consciousness, being needs felt as affects. Okay, so now we can move to, if that's not the unconscious, if the id is not the unconscious, if our instinctual driven affective life is not the unconscious, which it patently can't be. By the way, I should have said earlier, Freud said that the id is governed by the inexorable pleasure principle. How can an unconscious part of the mind be governed by a pleasure principle? I mean, have you ever heard of an unconscious pleasure? I mean, what is the point of an unconscious pleasure? There's an inherent contradiction in the model. It just doesn't work that way. It's not, even within its own terms, it can't be that the id is unconscious and governed by the pleasure principle. The reality principle is the unconscious bit. It's trying to get to automaticity, trying to get to learning how to meet your needs. So now we move to the unconscious proper. It's not the id, it's not the upper brainstem. It has everything to do with these memory systems. This is a very classical schema of the long-term memory systems of the human brain, and they're contrasted with what are called short-term memory. The long-term memory systems and the short-term memory systems coincide with the basic distinction between what is conscious and what is unconscious. Short-term memory just means here and now held in consciousness. Short-term memory, by the way, is a very small place. It has a very limited capacity. There's a very small number. Miller's law states it's roughly 7 plus or minus 2 bits of information you're able to hold in consciousness at any one point in time. So what's in consciousness, what's in short-term memory, is a tiny fraction of what's in long-term memory. Long-term memory is everything else. So if you think about everything that you've learned over your lifetime, all the bits of information that constitute your entire knowledge base, think how many bits of information that must be, how many billions of bits of information constitute everything you know, and then compare that number to roughly 7, you get a sense of just how small short-term memory, just how small cognitive consciousness is. Compared to what is currently out of consciousness. I say currently because the big distinction that we draw in long-term memory is between declarative and non-declarative forms of long-term memory. The declarative forms can be brought back into short-term memory. In other words, they can be brought back into consciousness. The non-declarative forms cannot. And this coincides with Freud's terms pre-conscious, which means descriptively unconscious, currently not conscious, but can be brought into consciousness at will, and Freud's term unconscious, which means, unlike pre-conscious, it is forevermore unconscious. It cannot be brought back into consciousness. That's what non-declarative means, as opposed to declarative. The way that this works, it works both in succession and in parallel. So I want to first of all describe the succession, and then I'll move to the parallel. You have something in short-term memory, which, as I said, is a very limited resource. So you use it sparingly. You're thinking about a problem. How am I going to solve this problem? How am I going to find my way from my home to my new job the first day that I go there? It's a very conscious cognitive act with your map, and you're trying to find your way, and anxieties and relief when you get there. Then you have an episodic memory of having done that. The next day, you can draw on Monday's memory when you go to work on Tuesday, and you can remember the whole episode, replay it in your head. On Wednesday, you have 2 episodic memories of going Monday and Tuesday, and you can replay both of them in your head. And eventually, if I can just cut the story short, eventually you're going to have thousands of memories, episodic memories, if you really used memory like that, which is clearly a very inefficient way of using memory. That's why we slowly consolidate from episodic memory. Sorry, the word consolidation I should have mentioned. You consolidate from short-term memory into long-term memory, and then you consolidate from episodic long-term memory into semantic long-term memory, which is making a sort of more general rule. So rather than remembering, on Monday I got there like this, on Tuesday I got there like this, on Wednesday I got there like this, you abstract them all, generalize them all into the third-person rules, the facts about how to get from your home to your job. And although you can retain some episodic memories, and you do retain some episodic memories, by and large you discard them. And you rely increasingly more on your semantic memory as to how to get to work. And then you even more deeply consolidate from that semantic memory into this over here, which is called procedural memory, one of the non-declarative forms of memory. And now it becomes a procedure, a skill or a habit, something that you do absolutely automatically and unconsciously. And once you've been driving the same route a fair number of times, you start to establish one of these forms of memories. And gradually, the center of gravity shifts not only from episodic to semantic, but ultimately to procedural memory. And so you've more and more deeply consolidated how to get to this place. While you're doing it now, you're thinking about other things. Your declarative memory, your short-term memory is preoccupied with things like, how am I going to deal with my boss? That's a problem I haven't solved. But how to get to work is a problem I have solved, so you don't waste your precious resource on that sort of memory. So it becomes unconscious, it becomes automatized, the solution, as the prediction as to how to get to work. And increasingly, as I say, the center of gravity shifts that way. That's why I'm sure, well, I don't know, but whether you have the same experience I have, I often go to work by mistake. When I'm actually meaning to go to the restaurant, I end up finding myself at my university. And that's from the ways that these systems work. And I'm just speaking so far about procedural memory. There are many non-declarative memory systems. The other one that's really important for us is emotional memory. That, like fear conditioning, which doesn't require multiple exposures, like procedural learning does. It happens absolutely with single exposure learning. You stick your finger in an electrical socket. You don't have to try it out again and see, over many, many trials, is this really as bad as I thought it was the first time? For obvious biological reasons, this one works differently. The important thing is that these systems here are what Freud called the unconscious. There is no controversy anymore as to whether there's a very large part of our memory systems which function unconsciously. In fact, as I said, the Barge and Chartrand review speaks of 95%. If you speak about bits of information, you can see how much information is processed in non-declarative memory compared to how much is processed in short-term declarative memory. It's a tiny, tiny, tiny fraction. So there's no longer any controversy that there is such a thing as the unconscious. So why don't we call it the unconscious? This is clearly the same thing as the preconscious. This is the same thing as the unconscious. Why do we call it non-declarative and declarative? Well, it's not only because nobody wants to give priority to Freud. It's also because they don't want to be confused with Freud. Because when cognitive neuroscientists rediscovered the unconscious, they discovered that it works the way that I've just told you. It's the automatizing of solutions. Things that work so well that you no longer need to clog up your short-term memory with them. This is a very wholesome place, the unconscious. It's where you have procedures that you can absolutely unthinkingly rely upon to deliver you to your destination, etc. Whereas the Freudian unconscious is a spooky place where, it's where the boogeymen are, and it's where precisely the opposite of where solutions are. It's where all your unresolved conflicts are. All the problems that are not solved. And so for this reason too, it would lead to confusion if we used the same term, if we called this the unconscious. psychoanalysts have been very happy to accept that the cognitive unconscious is a very different place from what they call the dynamic unconscious. But I want to put it to you that this is a false dichotomy. Oh, sorry, I see from this slide I meant to tell you something else. I should have said it's not just a matter of consolidating into long-term memory and into declarative memory and so on. It's also a matter of reconsolidating. So what declarative means is, as I said, as the word pre-conscious did, it means can be brought back into consciousness. When a declarative memory is brought back into consciousness, it is reconsolidated. That is to say that the proteins are literally dissolved, the memory is now rendered labile again, and then it's laid down in a new form. So it's an iterative process of consolidation and reconsolidation between short-term memory and long-term memory, and the declarative type is reconsolidated into consciousness, whereas the non-declarative type cannot be brought back into consciousness. So reconsolidation here is an additive process. It's a matter of, you can, of course, reconsolidate non-declarative memories, but not in the form of reconsidering them in consciousness, rethinking the whole thing in the way that I've just been describing to you. They work in two fundamentally different ways. Reconsolidation is a very interesting process for psychotherapy. Freud used this enigmatic phrase, which I think we can make sense of in light of what I've just said to you. He said consciousness arises instead of a memory trace. A memory trace is a fundamentally unconscious thing. All long-term memories are not in consciousness, not in short-term memory. They are descriptively unconscious. And so they are memory traces which are predictions which just get automatically executed unless they're brought back into consciousness where they become labile once more. And then it's a state of uncertainty. It's not a memory trace, it's a state of consciousness. So consciousness is uncertainty. Consciousness is, let me feel my way through this problem. Let me decide what to do. It's not predictable what I'm going to do. That's the conscious state. Once something is outside of consciousness in these long-term memory systems, they just get executed automatically. Although remember, these ones are subject to being brought back into the conscious state, and this is the special value of declarative memory systems, which are cortical memory systems. These are cortical memory systems. That's why they can be brought back to consciousness and rethought in images. These are not cortical systems, which is one of the reasons why they cannot be rethought. They don't take the shape of thoughts. They don't take the shape of images. They are not cortical things. They are subcortical processes. They are just action plans. They are responses. They are not images. They're not stories. They're not words. They function completely differently. So I was saying that this is a false dichotomy. I want to reiterate that both cognitive scientists and psychoanalysts are happy to agree that these are two different theories of the unconscious. They're describing unconscious cognitions using two completely different sets of assumptions. And of course, in science, this is an unacceptable state of affairs. You can't have two different unconsciouses. I mean, there's surely one part of human cognition that functions unconsciously, and there must be one set of rules that describes how this works. So I'd like to tell you, I don't agree, and I'm actually surprised that so much fuss has been made about this dichotomy. I don't see the dichotomy at all. Remember, the standard view is that the cognitive unconscious, the automatized unconscious, is automatized precisely because it works so well. That's why we have these subcortical, amygdala-centric or basal ganglia-centric response patterns, is that they are highly adaptive, automatic. There is no need for thought. In fact, thought is a bad thing. Delaying and indecision in this regard is not what's required. What's required is an automatic execution of a prediction that reliably works. The Freudian view is that in the unconscious, yes, there is that stuff, but there's also this other place, this other part of the unconscious, which is a seething cauldron of conflicts and as I said, spooks and nasty things that you don't want to know about, which you're deliberately trying to keep out of consciousness, precisely because you can't solve them. How can we reconcile these two things? Well, first of all, I'd like to make the obvious point that we don't only automatize solutions. It's just patently not true. Just think about addictions. You know, as I told you, there are different non-declarative memory systems, and they work in different ways. But you know, there are some habits, with the psychiatric meaning of habits, narcotic habits and whatnot, which are proceduralized. These are absolutely automatized. These are things that you absolutely compulsively do, unthinkingly do, automatically do. Any smoker will tell you about how these are procedure, how there's certain kinds of situations where you just automatically fall into doing that. This evokes that response. This is what I always do. And not only the simple example of addictions. There are many things that we do repetitively and automatically which are banging our heads against the wall. They are not adaptive, and they're not the right thing, and they're not so good, and they're not solutions. So this system that functions so automatically, that proceduralizes and habitualizes certain response patterns, does it for good things and for bad. I mean, it's obvious that this is true. Likewise, when you think about emotional responses, you know, the things that I've mentioned, fear conditioning. You guys know about PTSD, and you know about fear conditioning, and you know about how you can condition a certain fear response. Not because, I mean, the underlying biological mechanism is good, but it doesn't mean it's adaptive in the individual case. The mechanism gets recruited just as it does in the form of addictions. So it can get recruited in the form of PTSDs and phobias and so on, and maladaptive fear responses which function automatically in exactly the same way as all the others. We speak normally about fear when we speak about this emotional memory system, but it's not only fear. Think about the attachment system that I mentioned earlier. You know, attachment bonding happens in the first 6 months of life. How it happens is you have a look around, who's caring for me? Whoever is the most reliable giver of care, this is the person that you attach to. What if the best giver of care, or the most available or omnipresent giver of care, is a terrible caregiver? That's who you attach to. If you're stuck between a rock and a hard place, you attach to the best of a bad job. And that's who you've attached to. So these systems clearly don't only function for the good. That there are many spooks that get automatized. There are many bad things that get automatized. Many maladaptive, counterproductive, and giving rise to affects which are highly problematical to the individual. So I propose that what Freud called the repressed is simply that portion of what has been automatized, which has been, as it were, illegitimately automatized. Or in some instances, the term might better be prematurely automatized. In other words, the child has all of these needs, and remember, those instinctual needs that I spoke of are obligatory. We have to meet those needs. We all have fear, we all have rage, we all have the panic grief system and so on. We all have the play system. All of these needs are there. The child has to learn how to meet them. The child is not very well equipped as to how to. The child is dependent. The child is vulnerable. The child is not very knowledgeable. And so with its little 7 bits of information, it tries to resolve problems which it simply cannot resolve. Like, for example, here's a little Mark Solms, 3 years old, and he looks at his environment and he sees the parents seem to be in charge. You know, they always decide everything. I don't like that. I want to change it. I want to be in charge now. And so I think with my little 7 bits of information, how am I going to now take charge of this family? And you can think as long as you like about that problem. You're never actually going to resolve it. You're never going to come up with a solution as to how you get to drive the car and you get to go to work and order people about. You can see that the adults have all the parents. I want to be a parent. I want to make babies. I'm not exactly sure how, but I want to, you know. I want to make babies with her. She's nice. All these, the infamous Freudian Oedipus complex arises out of children wanting all sorts of things. I want to get rid of this guy. Shit, he's bigger than me. You know, let me think, how am I going to resolve this? So there are certain problems. Again, I think it is patently obvious that there are certain problems in life which are insoluble. And so the child has the simple choice of either thinking and thinking and thinking pointlessly and endlessly about insoluble problems, or it comes up with a childish solution, and that's the best of a bad job. It's the best it can make of the circumstances, and it automatizes the best that it can. So I think that repression is not something fundamentally different from the other automatization processes that I described. There's a gradient between those things which get automatized happily and adaptively for all the best of reasons, and then there are those things that we have to automatize because those systems simply work that way, and then there are those things that we have to automatize because we're cutting our losses, we're doing the best that we can. And so this is the situation that I think that we end up in. So the cognitive unconscious and the dynamic unconscious, I think the dynamic unconscious is that portion of the cognitive unconscious which has been prematurely or illegitimately automatized. So you want to know where the what is the unconscious and where is it located in the brain? Well, there it is. The basal ganglia and the amygdala, which forms the tail of the caudate nucleus, this is the core of the brain systems that Freud called the unconscious and that we call the unconscious. These are non-declarative, intrinsically non-declarative, never can be brought to consciousness aspects of cognition. They function absolutely automatically by what Freud calls the primary process. That is to say, there's no delay, there's no thought, there's no images, there's no holding of the thing in mind, which is what cortical cognition is capable of. These things are just action programs. They're automatic responses. Secondary process, delay, thinking, etc., is a cortical function. Now, I'm reaching the end of the allotted time for this part of the presentation. I'm going to go on to discussing clinical implications. If the things that I've said to you are correct, that this is the Freudian unconscious, which, by the way, Freud said had the following characteristics. He said it's timeless. Timeless just means not subject to revision. This stuff can't be brought back into consciousness and rethought. It can't be reconsolidated in working memory, in short-term memory. Freud said that there's tolerance of mutual contradiction in the unconscious. That's just another way of saying problem not solved. If it's mutually contradictory, that is not a solution. And that's what I'm saying, that part of those things which we automatize, because we can't resolve what to do about mummy who I need and mummy who irritates me. You come up with some solution which is mutually contradictory. That's because you have to. Freud says that in the unconscious there is internal reality dominates over external reality, which just means impervious to evidence. Once that thing has been automatized, no revision of it is going to occur. And then, of course, there's the famous repetition compulsion, which is the modus operandi of the basal ganglia. These function automatically, repetitively. That's their whole point. That's their whole way of functioning. So this system unconscious that Freud spoke of, first of all, it's not the same place as the id. It's not the same, it's not this upper brainstem and the limbic circuits arising from this which give rise to the demands made upon the mind for work. These demands are felt. They're felt as consciousness. The work that's then done is cognition to resolve these needs, to think our way through life's problems. We then automatize them into another part of the brain, not those upper brainstem structures. They are not memory structures. They don't learn anything from experience. Rather, into these subcortical non-declarative memory systems, something quite separate from what Freud called the id. And there we have these automatized, for good and for bad, these automatized ways of responding. If everything that I've said to you is correct, then we're left with two problems, which is what I want to speak to you about after the break. When I say break, first of all, there's a discussion, then there's a break. Then I want to speak to you about these two problems. I've already hinted at the first of them, that in psychoanalysis we're told that it's a talking cure. Freud said that words being derived from perception are capable of consciousness. These are cortical processes verbal processes, are cortical processes, they're perceptual, representational images. You can think them in working memory. And the talking cure rests upon the idea that these words must be dragged down into the inchoate unconscious id, where there are no images, so that we can think them. Where id was, there shall ego be, said Freud. And this is the whole rationale of the talking cure, dragging consciousness down into the unconscious id. If the id is in fact conscious, then we have to surely fundamentally reconsider what the talking cure actually is doing. Because it can't be dragging consciousness down into the part of the brain which is in fact where all the consciousness comes from in the first place. And verbal processes and cognitive processes are not inherently conscious processes at all. So this is one of the two questions I want to return to after the discussion and after the break. The second is perhaps even more troubling, which is that we are told that the mechanism of psychoanalytical cure, of this talking cure, is the undoing of repressions, the bringing back to consciousness of what was unconscious. This is the whole aim, is it not, of the talking cure. And yet, everything I've said to you about this shows that this kind of memory cannot be brought back to consciousness. That's in fact the very meaning of the word non-declarative, is that it cannot be declared. It cannot be. It's not a matter of choice. It's not a matter of trying very hard and then you can. This part of the brain functions absolutely automatically. And it is not only that it does descriptively, but also if you look at the brain mechanisms involved, and I'm doing all of this at a very high broad brushstroke level, I know, but these cortical memory traces, as I said, are images. They are literally patterns of stimulation that can be re-evoked, and this is why you can re-experience them as thoughts, that is to say, reactivated perceptions. These are not images. These are just response patterns. There's no way you can turn this into a thought. So it's sort of inconceivable that the mechanism of the treatment would be reconsolidating these in the form of turning them from automatized response patterns back into the memory that was originally there, that had been consolidated down into this other form. It's inconceivable that this could be reversed. So I think that we face some having answered the question in these broad brushstroke terms as to what is the unconscious, given everything that we've learned in the last 100 years or the last several decades actually in regard to the topics that I've talked to you about, most of what we've learned has been in the last few decades. Given what we've learned, that what Freud called the id and what Freud called the unconscious can't be the same thing, that the id is in fact conscious, that this is the source of all of these feelings which are all too conscious, and that the unconscious is something separate, and also that the unconscious can't be brought back to consciousness. This is just not at all how it works. It's sort of physiologically impossible to imagine that you could reconsolidate from a basal ganglia procedural response pattern back into memories, which now you can think in episodic memory again. Given that these are the conclusions we're driven to based on the knowledge that we've gathered over the last few decades about these functions of the mind, how does psychotherapy really work then? How might we reconsider what we're doing in psychotherapy? And that's what I want to address with you after the break. Thanks very much.
So we have time for questions. I think we have microphones.
There was a microphone.
There are two microphones here. Oh, you got it. Perfect. So they will. You'll chase down the folks who are going to answer the questions.
I don't see the microphone. Oh, there they are.
Yeah.
Okay.
Thank you for a fantastic talk. I wonder about what I think of as the strategic unconscious. I mean, there are things that are held out of consciousness because they're distressing and disorganizing to the individual. But there are also things that are held out of consciousness because, for kind of negotiation reasons, to manage relationships. And I'm wondering how you think of that.
Yeah. So I think if I can put that slide back up, I think it proves to be very important in terms of what we do as therapists. And when I say as therapists, I mean, let's not forget each of us are our own therapists all the time. So it's also what we do just in the living of our lives and the making of our decisions on the hoof as to what we're going to do and what we're not going to do. That this distinction is terribly important between those things which are unconscious and cannot be brought back to consciousness, and those things which are also unconscious but can. There's a great deal that is unconscious which can be brought back to consciousness, and this is what Freud called the pre-conscious. And he also made the point, if I may go for a moment into some arcane Freudian theory, that there is a resistance between consciousness and the pre-conscious just as much as there's a resistance between the pre-conscious and the unconscious. So what that means is that there are also many things which we can think about which we would rather not think about, but we can. And when it comes to psychotherapeutic technique, you're therefore in a very different kettle of fish. If you have a patient who doesn't want to think about something, is holding it out of mind strategically, whether it be for rational strategic reasons or for irrational strategic reasons, nevertheless, that's something they don't want to think about. I think that you have at your disposal a great many different techniques that you don't have at your disposal when it comes to this. So, in response to your question, yes, I think it's important that we remember. I think that we tend, by we I mean now psychoanalysts, I think that we tend to sort of be over-inclusive in our use of the word unconscious. I think that there's a great deal that we call too loosely unconscious, which is really pre-conscious. And I think that this has important implications for what we do with our patients. And when I say what we do with our patients, I don't only mean what we psychoanalysts do. I mean, I don't think psychoanalysis is necessary for everyone. You know, there are many other psychotherapeutic techniques which can deal with the sorts of problems you're talking about, where it's something the patient can think about. And I think that it's important that we acknowledge that.
Thank you for that great talk. So I'm trying to understand what your definition of feelings is, basically. You sort of described this model in which a feeling arises whenever something is presented, like an image from reality that's presented that somehow is distinct from our prediction, our unconscious prediction of what's supposed to be happening. Is that correct? Or
I don't. So let me clarify or answer what you've said there. I gather that you're then going to go on to something else. You're not sure. Okay, because I wouldn't use the word image. What we're dealing with here are measurements rather than pictures. You know, so I think that cortical functions are images. They are representations. It's in their nature that they are imagistic. These upper brainstem arousal functions are measurements of deviations from settling points. This is where the organism expects to be, and it's not there. So it has to get back, and it uses images. It uses, then the world becomes salient. So the feeling of your way through the cognitive processes of what I've done isn't working, what I'm doing isn't working, what else can I do to get myself back to, and the feeling of your way through the images then renders them conscious. So what I'm saying is, let me not claim ownership of this idea. What I'm saying is basic Damasio. It's the view that Damasio, in his last two books, the Self Comes to Mind and The Strange Order of Things, that's what he argues, and I find that very compelling. Remember that the starting point of what I'm saying is that we have to recognize two things. The one is that all consciousness comes from the upper brainstem. This is not controversial. And secondly, and this is the novelty, that upper brainstem consciousness is affective. So the question then becomes, well, what is consciousness for if it's fundamentally affective? And why does cognition have to become conscious ever if it's perfectly capable of doing its thing without becoming conscious? And the answer is, it's perfectly capable of doing its own thing without becoming conscious if what it's doing is already predicted. In other words, if what it's doing can be done and done and done again. If in the doing of it doesn't work, then there's prediction error. Then the feeling comes back because the thing hasn't worked. It hasn't met the underlying need. The feeling coming back is what then renders the cortical or the cognitive prediction salient again. And you then, as to use that quote of Freud's, consciousness arises instead of a memory trace. In other words, instead of an automatic prediction, I now have a choice. I now have the possibility of choice. That's what feeling is for. That's what value is for. There would be no possibility of making a choice if there wasn't a good and a bad. There has to be some basis for deciding left versus right. And feeling is the basic value system of living organisms. And the reason that we have to feel is so that we can make choices in unpredicted situations.
So I actually do have one follow-up question to that. And in your
I'm a psychoanalyst, I know what you think.
So then in your perspective, are all prediction errors feelings, or is it only like a certain subset of things that deviate from your predictions that become conscious and guide then cognition?
So you must remember that homeostasis goes from the top to the bottom. It's like the basic rule governing all living things. And that includes autonomic reflexes. They too are, in a manner of speaking, predictions. When this happens, do that. And there are many predictions that are 100% reliable, and you don't have any thought involved, no consciousness about them at all. So feeling doesn't attach to every form of prediction. Feeling attaches to prediction error when the automatic correction mechanism cannot be relied upon. And this is in states of uncertainty. And this, as I said, reaches its epitome. It's sort of the greatest likelihood of occurring when it comes to these emotional needs, where there's so many degrees of freedom, and it's so impossible to learn how to always have a solution that will always reliably work. They're much more context dependent, and they're not only dependent on the context in relation to this situation versus that one, but also the context of competing needs, how they can be resolved in relation to each other. So, yes, feeling always entails prediction error, but prediction error doesn't always entail feeling. There are automatized ways of dealing with prediction error. That's basic bodily homeostasis. And then there are these ways of dealing with uncertainty in relation to and there's an enormous adaptive advantage of that because it enables us to survive in unpredicted environments and in changing contexts and so on.
Thank you.
Thanks.
Thank you so much for your talk. It was really, really enjoyable and compelling. I have a couple of things I wanted to follow up on. I'll just say them all at the same time. 2 questions and a comment. The first is that you're saying that this non-declarative side is tantamount to what's described as repression, but there's an aspect of repression where, try as one might, it's very difficult to bring things into conscious cognition where you see all kinds of evidence of words and images sort of in an unconscious way, and I'm not sure where in this scheme of that particular phenomenon is explained. So that's one question. The second is about a good old standby guilt. I'm sure that fits somewhere into your affective schema, Panskip's affective schema, but I'm not sure where you place it. And then we might as well throw in shame there as well. Yep. And then the third comment I wanted to make is that it's interesting to me to correlate these with Freud's structural model, which is what you're doing. But of course, there are so many interesting models which are psychoanalytic models which are directly focused on mechanisms other than insight, which is what you're critiquing here, and specifically on the unrepresented mental states with which we deal all the time. And I'm wondering, do you have thoughts about those and have those come into your work as well?
Yep. So I'll start with the third one first, and then I'll move backwards. I'm very mindful of the fact that what I'm talking about is Freud, and that the whole of psychoanalysis does not coincide with Freud, that there's 6 decades, 7 decades, 8 decades of psychoanalysis since Freud. The reason that I focus on Freud is precisely because there's so many different schools of psychoanalysis that I can't make connections with the neurosciences with 7 and 8 or 9 different theories at the same time. So what I do is I start with their common denominator. All psychoanalytical schools start with Freud. And so I'm starting there in terms of trying to make some sort of sense of basic psychoanalytical concepts in relation to contemporary neuroscientific concepts. That breaks down barriers between psychoanalysis and the cognitive neurosciences and so on. But I hope, and I'm not doing this explicitly, when I say I hope, I think there's very good reason to hope that it will simultaneously break down barriers between different schools. Because in making those connections, so it becomes apparent, as I think you're sort of implicitly saying, well, for example, much of what you said there, Mark Solms, Beyond says that. Much of what you're saying there about the limits of undoing repressions, we've long ago realized that and so on. So I'm hoping that some of let's be honest I'm a psychoanalyst and I love psychoanalysis. I think that it has an enormous amount to offer psychiatry and the world, but it also has enormous faults. And one of them is this kind of doctrinaire, I support Manchester United, you support Liverpool, and there's no place, for that sort of thing in Manchester United. So I'm hoping that by making links between the most basic of psychoanalytic concepts and really solid mainstream evidence where we have really good methods for being able to demonstrate the truth of what we're saying and so on about brain function, that some of the foundations for this kind of school making in psychoanalysis will be undermined. So I'm very much aware that some of the things I say, like for example I mentioned in passing, Freud and Anna Freud and the ego psychologists were of the view that there's a libidinal drive which includes attachment, and it's just patently wrong. And so there you have something in favor of Fairbairn and Winnicott and the object relational people, which, but I try to not put it into sectarian terms. I'm trying to just say, well, the evidence is, and then I'm hoping that the psychoanalytical schools will reorganize themselves accordingly, slowly.
Good luck.
Yes, good luck. Your second question about guilt and shame, that's a very important point. I said that there are 3 broad categories of affect, and there's the sort of bodily homeostatic affects and the sensory affects, and I leave them out because they don't play much of a part in psychopathology, precisely because they're so easy to deal with. It's not that they play no part. Like eating disorders exist, masochism exists, and so on. But it's not because people with eating disorders don't not know how to eat. They don't not know how to meet the need of hunger. It's because other emotional needs contaminate these more basic homeostatic functions. So the 7 that I focused on, the 7 basic emotions as Panksepp calls them, and they're different, as I said, classifications. For example, Ekman calls disgust a basic emotion. Panksepp calls it a sensory affect. I don't think that's really important. The important thing is this, to get to your question, that these basic emotions are the natural kinds in terms of the circuitries and the chemistries and the behavioral phenotypes that are built into the mammalian brain. That doesn't mean they're the only emotions. Clearly, in psychological, psychotherapeutic work, we come across guilt all the time. We come across shame all the time. You mentioned just those 2, to be kind to me. The same applies to envy. The same applies to jealousy. These things exist in abundance, but they are not natural kinds that are built into the brain. So this raises the question, well, where do they come from? The answer is twofold, and they're kind of overlapping answers. The one is that they are amalgams of, guilt, which is your first example. I actually alluded to it without using the word when I said that there's a ubiquitous conflict between your attachment, your love for your attachment figure who you want to keep safely, always looking after you and by your side, and the inevitable fact that she's also going to enrage you and you therefore want to annihilate her. That conflict gives rise to guilt. Guilt is the conflict between attachment, bonding, and rage. And that's one aspect. When I said there are two factors. So the one is that there are amalgams between basic emotions which are ubiquitous, which is why something like guilt is ubiquitous. It's not that it doesn't exist in every human heart. It's just that there isn't a circuit for guilt. It's something that's a resultant of two other forces. The other factor is that there are basic emotions, and then there's the cognitive elaboration of them. For the reasons that I've already described, I hope I got that across, that one of the main points of the relation between what Freud called id and ego is that the basic instinctual machinery we're born with is not enough. You need to learn from experience in order to nuance and elaborate and synthesize, the different needs, emotional needs in particular, with each other. So the cognitive component is the elaboration of the basic emotions. So many of these emotions, which again are so commonplace, are in fact not basic emotions, they're emotion-cognition amalgams. The example of shame, I think was the second one you used. Just think about what shame actually entails. I feel like this because I think that he thinks this about me. There's a lot of cognitive gymnastics there that's not built into a basic instinctual emotional circuit. Again, it's a very common. If you think about what I said about play, and how it necessitates your taking account of the affective mind of the other, it's going to lead to things like shame. Shame is obviously going to arise, but it's not a basic emotion built into the basic limbic circuitry. Thank you.
I also have two questions. What you were just saying about the comment around multiple series and multiple models and the hope that somehow or another that will break down, and what you had said earlier about when the predictive responses that are in the non-declarative system are becoming or need to become conscious. When something needs to become conscious again, that results in uncertainty. So one of my questions is, would it make sense to say that part of the difficulty of our field as psychotherapists and psychoanalysts is that we are continually entering into states of mind with people who are not predictable to us to a great degree, and we are needing perhaps to constantly stay conscious of our internal states in order to attempt to become, to understand, which is another word I would say for, understanding what is going to be predictable, perhaps. So that uncertainty, is that something that has perhaps driven our field to manualize, to always be making something certain, which in and of itself creates the conundrum of our field? That's question number one. Which leads to question number two. I know that's a big one, the first one. The play system, I've read elsewhere that some consider psychotherapy or psychoanalysis play, as defined as a place where something can be done without the consequences of reality, as you were describing before. How would you think of psychotherapy along those lines in the play system?
Yeah. So, thanks. I was slightly distracted as I was listening to your question, because I realized you had three and I only answered two.
I was hogging up a lot of times.
Okay. Forgive me. If time allows, we can go back to it. So your first point, I think that, I very much agree with you. I think that, however, we mustn't when I say I very much agree with you, let me say what I think you said, which I agree with. I think that what we are trying to do in our work, by which I mean psychoanalysis, but also I think many other psychotherapies, and just sort of other sort of ways in which one should live one's life, is to tolerate uncertainty. I think that for all of the reasons that I have outlined, both you can see why the tolerance of uncertainty is openness to learning from experience, the possibility of being able to be surprised and to find something that works better than what you were doing before, not sticking with something out of anxiety just because it's the devil you know, and so on. So uncertainty is clearly there's a great deal to be gained from tolerating uncertainty. Clearly also in relation to everything that I said, there are forces at work in the mind, by which I mean in the design of the mind, and it's apparent why that should be the case, that there's also a need to automatize, that you can't be in a state of constant surprise and constant uncertainty. Just to mention the most obvious of reasons, it's because working memory is such a limited resource. You only have this much capacity. That also begs the question, why do we have so little capacity? It's also because there's a bottleneck on action. You can only do so many, you can only think so many steps ahead. So the need to automatize, the need to find solutions, the need to be able to delegate that is to unconscious memory and response systems, and to not have to constantly decide afresh all the time how to do things. I mean, think about your tennis game. If you had to rethink your stroke every single time you play it, you would be hopeless. And in fact, it's a very good way to undermine your opponent, is to try and make them think about the stroke, because it's such an inefficient way of functioning. So I think that we need to recognize, I'm sorry if I'm saying something sort of disappointing, but I think that on the one hand, we are trying to encourage tolerance of uncertainty in ourselves and in our patients, because it means the possibility of finding better and newer solutions. But we also have to recognize that the resistances to that are there for good reason, that we can't be in a state of obsessional uncertainty forever. And I think that the same can be said about our field, if I may now add this to what you said. That, we're told, for example, by Bjorn, who I tried to give a compliment to earlier, that we must operate without memory and desire. And I just think that's not possible. That sort of state of mind is not possible. It's some kind of ideal. It's a kind of an aphorism. I can even see how, in a limited sense it's true, as long as you remember the limitations within which it's true. But for heaven's sake, why do we train if we don't have memory? If we don't use memory, why don't we all just say, I'm a psychoanalyst, I'm going to sit here without memory and desire? You go through years of training. I think it's a matter of us also recognizing, therefore, that there are certain automatized, certain manuals, if you will, and I know why you're using the word manual. There's certain regularities. Life is not an endlessly open book where there's absolutely nothing that we know, where there's no laws governing the human mind, and therefore we have to be ready for anything at all times. I just don't think that's true either. So I think going to our discipline, I think that we must also have doubts. God knows we need this in psychoanalysis. We need to have doubts about our theories and doubts about their veracity, and be ready to question heartfelt assumptions. But it doesn't mean we know nothing and that there are no regularities and so on. So it's a matter of that balance also in our fields. Yeah. Now, the second, Josh, so I think I'm agreeing with you. The second point about play, I agree very much with that also, that play, the first thing that you said two things about it. I agree with both of them. The first thing that you said is that many people say that psychotherapy is itself a play situation. And, I don't want to trivialize it, psychotherapy that is, by saying that, because play is considered such a sort of frivolous thing. But in light of what I've said, I hope that you can see I don't consider play to be a frivolous thing at all. I think play is a very important activity. And the ways in which the psychotherapeutic situation is similar or analogous to, or perhaps even grounded ultimately biologically on the play situation, is that there are these rules. about what their boundaries, what's permissible and what's not possible. If you cross those boundaries, therapy is impossible, just like play is impossible. And within those boundaries, then there's the possibility, and there's a hierarchy also, which we have to recognize. There's a hierarchy, there is. But it's not everything I say goes and you are my pupil and you're going to learn. There has to be a reciprocity, there has to be a give and take. And then within those balance, which is what I was going to say earlier, there comes the possibility of being able to try things out. And the as-ifness of that is terribly important also, that it's, I'm not actually in love with my therapist, I'm not actually going to sleep with her. I can talk about it, I can fantasize about it, I can play with the idea. I don't mean in a perverse way, that one can test it out, one can, because of the safety of those, of the boundaries and the rules of the situation. And also the reinventing of oneself. And when I think that the whole social mobility, and I don't just mean in terms of top dog and bottom dog in the crudest sense of the word, but the whole trying out of things and allowing yourself to become something else. That's what happens in play in childhood, and I think that it remains throughout life. All of these instinctual mechanisms, of course, remain with us throughout life. The first attachment is not the last attachment, but the same mechanism is used all the way through. I think the same applies to play. A patient who cannot play has a great deal of difficulty using psychotherapy. Thank you.
So let's stop here. We have a few minutes for coffee and to catch up with folks you haven't seen since last year.
What time do we start again?
So let's please be back here by 3:30 so we can get started.
Thank you.